So we have about 20 minutes, and I'd like to open it up to questions from the audience. There's a microphone on the left, I think, and right there, yeah, right back there. And maybe while you're all lining up, I'll throw one out to the group. So, we talked quite a bit about outcomes measures, both from the provider side and the payer side. What would you describe as the key outcome measures that we really need to have in place to define the success of these types of programs, both in terms of quality, but also to think about how to align with value-based reimbursement? Anyone can take that.
So at Baylor, we think we do two things. We do care planning, so you need outcomes-based measures related to care planning. And one of the most basics is creating one or more new advanced directives. That for us is an important metric that we track. Texas doesn't have a POLST or a MOST paradigm, but we have our own private MOST form. We use that as a care planning metric. Initially, it's one we placed upon our supporting palliative care teams, but now we're shifting it towards each hospital in particular, not just the palliative care team, and trying to make it a metric for the hospitalists who see the majority of patients who are being discharged to skilled nursing facilities. And getting appropriate changes in code status, trying to decrease the number of non-beneficial CPRs that are attempted. And then on the palliation side, tracking symptom outcomes. I think those are really important. And we see, across our 14 hospitals, we see variability in these. And I went through a lot of the slides very, very quickly. Please take some time to look at them. And if you have questions, feel free to email me, and I can give you examples and show you how it varies across a single system.
Thank you. Anyone else?
Sorry. We're probably aligned on many metrics, but I would be remiss if I didn't say that the experience that either the individual or their caregivers and families have is a critical outcome for us. One of the challenges is how do you really measure the experience beyond the typical satisfaction scores that are out there in the marketplace, and we're thinking about that and trying to figure out how best to do that.
Yeah, and I have to say the same thing. That's the one we really struggle with. I mean, how do you measure satisfaction in this space? And it's very, very challenging, and it requires different kinds of questions than the ones that are typically used today in healthcare. Why don't we start over here on the left? Thanks.
Theresa Lee with VNA Health Group, and I just want to thank the panelists. I think each of you are, just had such tremendous things to say about your respective programs. So first, as I mentioned before, VNA Health Group, my organization, we're in the Medicare Care Choices model. We participate in CPC Plus. I think in this panel is talking about lessons learned. I think from our perspective, we're still learning lessons in both of those models. They're still ongoing. CPC Plus especially, that's just getting off the ground for us. We're really unique in that the physicians we have participating in CPC Plus, they're home care physicians. And so CPC Plus is not, I don't think it was initially envisioned for home care medicine, but the way we see it is that it's a much better construct for innovation, I think, in a way than some of the shared savings models, because we're really going towards capitation, and it's giving our visiting physicians and nurse practitioners the ability to innovate and have the funds up front and make investments in practice transformation and also in just various different innovative practices generally. So we're looking at whether there need to be tweaks in terms of things like quality measures for the seriously ill population in CPC Plus. Also, whether there might need to be further risk adjustment payment changes to enable our visiting physicians to really adequately treat seriously ill populations, because essentially the patients we treat are homebound in the visiting physician service in CPC Plus. So that's the first thing. In the Medicare Care Choices model, we have more experience. We were the first cohort, and we stuck with it. There were many who didn't stick with it. One of the big challenges there is just payment adequacy, straight up payment adequacy. And I think that, we've stuck with it because we have a commitment and belief in really treating a population that's pre-hospice, trying to get at the seriously ill population concurrent with curative treatment. But really, the payment is only about $400 a month. And so it's not really adequate to comprehensively, within that payment rate, comprehensively provide hospice plus curative. I mean, the curative is there, but so we're running a really significant operating deficit. We're doing a great job. If you look at our data, we have great outcomes. So one thing I think is going to be important for CMS in its evaluation is to collect the operating cost data and to look at what services are actually being delivered and see how they match up with outcomes. Because for our organization, we view it as, no, we committed to providing hospice level care with curative treatment. And I think that others might only be providing just phone calls and not going into the home. We're actually going into the home. So in the evaluation, I think that's critical. And anyway, the last thing I just wanted to encourage everybody to think about is that among the panelists up at the table, the private payers basically are thinking of hospice programs as being 12 months out and concurrent with curative treatment. And so I just find myself thinking that maybe that's the direction we need to think about in terms of hospice modernization. Thank you.
Thank you very much. Question over there?
Yes, hi, I'm Alison. Oh, everyone's shifting. Alison Silver from the Center to Advance Palliative Care. I'll also have to thank the panelists.
A little louder,
Is
please.
this on? I don't think it's on. Oh, okay. Can you hear me now?
Yes.
Got it. Okay. Anyway, I wanted to thank the panelists, and I appreciate that there's a lot of investment in building on a fee-for-service infrastructure. The speaker just talked about the $400. You talked about the CPC plus case management fee. We're chipping away in fee-for-service to make sure that there's sufficient compensation for time for providers to pay more attention to the seriously ill. I have a question about investment as well, and I think, Anthem, you alluded to supporting providers getting the skills that they need to hold those important conversations and pay attention to the seriously ill in a different way. I was wondering, for the whole panel, especially Cambia and Anthem, do you feel like there's additional work to be done in investment in getting the health system up to speed and the skills that they need? And do you think that payers are really going to step up to the plate for that?
So I think we're only scratching the surface in terms of education and support for our network providers, whether they are in value-based payment arrangements or they're part of our broader PPO network. I think our anecdotal feedback is they don't, generally speaking, have the skills. They need help and the support. And to the extent that we can provide that support, we're working with them, creating educational sessions and the one-on-one types of meetings that we have in the context of our value-based payment arrangements. But I would say I don't think it's enough, and I'm not sure exactly what the next steps are, other than more intensive collaboration and training.
Yeah, I would just echo that. I think when we think about primary palliative care solutions, we are concerned that the practice, the staff, and the physicians need training. I think we envision a situation in which they are participating in some sort of value-based payment model, and the payer participates in training the practice. I know there's a course that we have looked at Cal State for the Center of Palliative Care that we think has some potential for being used in scale, which that's, I think, the biggest concern is, how do we flip the switch and get everybody trained? But I think it's certainly on our radar screen, and I think that we feel that that's got to be a necessary part of this.
Just a follow-up, so, oh, go ahead.
Sorry. I know I'm not responsible for an insurance program, but having been doing this for over 20 years, I think the hospice world has been trying to educate for over decades and unsuccessfully. And I'm not sure that that methodology is going to be any better with an insurance-backed concept of education because of the expertise. Now, having conversations, if someone's open to that, I think is wonderful, but having the palliative care conversations about choices and the risks and what options you have, I personally believe that sometimes you can't instill that in every provider. You need to be able to provide a resource for them to turn to have those conversations.
So just one more reaction, if I may. So these questions and the issues that are being brought up about what is important, including training, to train to what information, I'm hoping that many of these comments were submitted in response to the Innovation Center's RFI that closed on Monday. Because I think this is really important. Even the clarity about the population that this conversation relates to. I do think in a separate space, this is not, about specific to hospice care or palliative care, and practices are learning to redesign themselves, right? And there's a model test underway called Transforming Clinical Practice Initiative that helps practices understand their costs, using data to better inform what services need to be delivered to deliver to better outcomes and experience of care for patients. So these are concepts that are not, I think they're important to palliative care and to this conversation, but I think there's an opportunity that comes in the form of practice redesign and the technical assistance that's being provided. So just to call that out, and certainly, there's a change package as part of this that talks about data and all. So send us information.
We'll take a question over here.
Good morning. First, I'd like to thank the panel for excellent presentations. My name is Dr. James Block. I'm a consultant to the Center to Advance Palliative Care and also to the National Palliative Care Research Center. And I guess you would say I'm a palliative care groupie. I'm very impressed with what the payers are doing, and I'd like to ask this question of the payers particularly. I'm curious how transparent all of your activities are to the employers who are your customers. How much are you sharing with them of what you're doing? How much are they demanding of you that you do these kinds of things? What are you telling them? What is the cost of the benefit? Are they open to the benefit? Are they willing to elaborate the benefit? What is that communication like? I'd like to sit in on one of those sales pitches and listen to it. Can you tell us a little bit more what that's like?
I get to plead a little bit of ignorance since I've only been in my position since June 1st, so I haven't had any employer conversations. But it's my understanding that we're pretty transparent, and it's also my understanding that employers are coming to us to demand improvement in this realm. So I think it is a conversation that is going on. With any large company, there's always some concern about messaging, and so, but this is something that's on the radar screen of the employers. It's my understanding.
So I would say, in contrast to 10 years ago, we're actually able to have this conversation and have it in a transparent way. and that is progress. I recently had an opportunity to meet with one of our largest accounts and talk about our palliative care program. And I would say they were astonished, candidly, at the scope of what we're doing, both on the foundation side, as I described, as well as the services that we're covering on the health plan side. We're very interested in pursuing efforts on behalf of their employees relative to palliative care. So I'd say that we've been transparent. There's been interest and uptake, but we have more work to do in that area.
Thank you.
Thank you.
Question over here?
Yes, hello. My name is Becky Shipp, and I'm a recovering health staffer now with the Sheridan Group. I spent over 15 years on the Senate Finance Committee, and one of the pieces of legislation I worked on was the 2005 Deficit Reduction Act, which established the Money Follows the Person and Home and Community-Based Services Program. And so my question is a little bit of self-interest. In your view, from the field, are these programs working? I know they're state-based, and I know they're not in every state, but in states that they are in, are they functioning? Because the intent of Congress was to target these programs to the palliative care population. And so I'm just curious, in your view, did we mess up? Did we do a good job? Can we have improved it?
Who wants to take that?
Oh no, I've stumped the panel.
I can start. Our real expert actually is Ellen Blackwell here, but I will say, it provides important access to services. The challenge that we have is that when any evaluation is done, you have to have consistent measures, right? And to be able to evaluate things in a rigorous fashion. And part of that is also the evaluation of quality. And so what quality looks like, that's an important area of work that I think we're getting to through the National Quality Forum's efforts. And I don't know if Ellen wants to say more about this.
Use this.
Okay. Yes, I would. Oh, thank you. I was, in answer your question, did these DRA programs that support home and community-based services and institutional transition work? Yes, absolutely. The DRA made it much easier for states in the Medicaid program to effectuate transition programs and home and community-based services in other more easier administrative ways. And over the past 12 years and the past 30 years, we've seen this complete rebalancing of the system where we have more than 50% of our home and of our services in Medicaid for people who are receiving long-term care are received in community settings. So I would say absolutely. And we've heard this today, that one of the problems that people with serious illness face is that the Medicare program has a deficit of such services. So yes.
Thank you. Let's take a question over here so we can keep on going. Yeah.
Thank you. I'm Peggy McGuire from Cambia Health Solutions. I oversee Cambia's comprehensive approach to palliative care and also serve as the president of the Cambia Health Foundation. I have a question, and I have a backup question in case you can't answer this. So I have a question for Dr. DeBono, which you may have already told me you can't answer. But looking at Anthem's program, which has such an expansive reach in terms of the provider network and the number of people served, what barriers did you face in moving that program from the evaluation state to implementation?
I wasn't involved with the rollout, but this was I would say, a highly orchestrated initiative. And I would say the barriers are just committing the resources necessary. I mean, this is a broad, you're referring to the enhanced personal health care
Yes.
program. And it does have significant scale, very large breadth throughout the company. And we had to think long and hard about what resources the providers needed to sort of go over the finish line and actually execute. So there was a lot of discussion about what exactly infrastructure was going to be required for these providers to really sort of take the plunge. So I don't think the concept of, you know, improving patient-centered care and as a result improving palliative care was a concept that was getting a lot of resistance within the company. So I think, you know, there was, I think, an all-in kind of attitude about the program, and we're now trying to coordinate the EPHC model with oncology, and that's so kind of the next steps. That's sort of my understanding of the program, and it is a very resource-intensive program, but it's paying off for Anthem.
And on that note, I want to thank our panelists for an outstanding job, and thank you all for your questions. Let's give them a round of applause.